Welcome everyone to the third series in the INYNF case-based webinars. And as per our usual strategy, we have been dealing with the themes for each session. So today's theme is neuroimmunology, and we have two cases on the same theme. The session coordinator is Dr. Shreyasi Jha. So without further ado, I would request Shreyasi to kindly take over the proceedings, introduce the speakers and the moderators for the session.
Right. Good morning, madam. Good morning to everybody. With the launch of acrelizumab recently this month, becomes all the more pertinent that we have our theme centered around neuroimmunology today. We have two very interesting case discussions from the All India Institute of Medical Sciences, Delhi and RML Lucknow. So the first case will be presented by Dr. Siddharth and will be moderated by Dr. Ayush Agarwal, sir. And the second case will be presented by Dr. Rohit and moderated by Dr. Abdul Kavisa from RML Lucknow. So we have a senior moderator, Dr. Shruti Nair, additional professor from Sri Chitra. Madam, welcome, madam. Okay. So, Devyani ma'am, shall we start with the first case discussion?
Yes, go ahead, Shreyasi.
Yes, please. I would invite Dr. Siddharth to please present his first case.
Yeah. Is my slides visible? And
yes, it is visible. Yes.
I'm audible, right?
Yes, you're audible also.
So, good morning, everyone. I am Dr. Siddharth, senior resident from Neurology, AIMS Delhi. So I would be presenting my case on balancing an immune trio. So the patient is a 54-year-old male, right-handed, resident of Meerut, and is working in a construction work. He presented with chief complaints of burning and tingling paresthesia of all the limbs, and the total duration was 2 years. And he also had imbalance while walking with falls predominantly in the night since 1.5 years. And he had some involuntary movements of the hands and feet since past 1 year. And he had symptoms in the form of difficulty in swallowing since past 3 months. So initially, 2 years back, he had some prodromal illness in the form of some fever, which was low grade and non-localizing and associated with multiple episodes of loose stools. And they were non-mucoid, non-blood stained, and without any other focal signs of the fever. So 1 month after the resolution of the fever and loose stools, he took some treatment and it got resolved. So he developed a burning sensation predominantly in the distal upper and lower limb in the form of hands and feet. And it was associated with burning, tingling, and numbness. And these symptoms had progressed. It started from the hands and feet, and it had ascended up to involve up to the bilateral shoulder and bilateral hip over a period of like 6 months. Then he started to have cotton wool like sensation on walking, and at that time he was having slippage of chappals, which was without awareness, and he had falls predominantly in the night, and he also had the wash basins phenomena which was seen. And he reported that whenever he was walking, he was not able to walk without support. And during walk, he required very high steps to walk, and he always used to see the floor while walking. And this was gradually progressing. And eventually, he required one person support since the last 1 year before presentation. And since 1 year, he also started to have some weakness, which was started in the upper limb and then followed by the lower limb. And it was associated with wasting of both the hands also. But it was associated with some flabbiness, and he was not able to do his activities as he was doing earlier. And for holding and reaching any objects, he reported that he had some tremulousness, and he was not able to coordinate properly. And he also reported some random flow-like movements involving the upper and lower limb and face and the perioral region. And he reported that it got aggravated predominantly in the evening and night and on closing the eyes. And these symptoms were recent since 6 months, and all his symptoms were progressing over a period of 2 years. And when he presented to us, he was not able to stand, he was not able to walk. And even in sitting posture, he was feeling extremely imbalanced and with a tendency to sway towards either side. And he required one person support constantly. And he also had recent symptom of difficulty in swallowing, which was more for solids as compared to liquids, but there was no voice change or no nasal regurgitation. And he had undocumented weight loss for approximately 3 months. So there was no complaint of any radicular pain or band-like sensation, no complaint of any visual symptoms, facial deviation, or any decreased sensation over the face. No complaint of any abnormal twisting movement or any myoclonic jerks or any posturing. And there was no bowel bladder habits were normal, and there was no fasciculations, cramps, or any stiffness of the limbs. And he did not report any abnormal autonomic dysfunction in the form of any sweating, palpitations, or erectile dysfunction. And there were no other systemic features, no history of any oral ulcers, genital ulcers, or any dry mouth or joint pain or rash. And so there, in past history, he was not a diabetic, hypertensive, or any other comorbidities. There was no exposure to any toxins. He was only a worker in the department of the construction, where he used to only deliver the products. Otherwise, there was no exposure. And he used some denture without any creams. And there was some Ayurvedic drug intake in the past as well for these symptoms. And he was a chronic smoker. He had 3 to 4 BDs per day for 30 years. So the smoking index was 120. Apart from that, rest of the sleep, bowel, bladder was normal. There was no family history. And treatment-wise, he only took some gabapentin multivitamins apart from the Ayurvedic drug that he had taken. So to summarize, this patient is a 54-year-old gentleman with background history of chronic smoker without any other comorbidities, and total duration of symptoms being 2 years, with insidious onset, gradually progressive, chronic neurological illness in the form of positive sensory symptoms, sensory ataxia, motor weakness, which was upper limb followed by lower limb, and there was also associated wasting. With some chorioethitoid movements, basically predominantly aggravated in the dark and closing the eyes. So probably pseudoethitosis with bulbar involvement and background significant weight loss. And without any other sensory level, bowel, bladder involvement, or any other cranial nerve involvement. So to analyze my symptoms of these patients, basically for the sensory complaints, it was more of a burning sensation to start with, followed by tingling, paresthesia, numbness. So this burning character pointed towards whether if it is a small fiber involvement, or burning can also be seen in dorsal root ganglia involvement. And for the ataxia that he had complained, where he had significant imbalance while walking, high steppage gait, and the predominant symptoms occurring in the night with wash basin phenomena. So I'd like to keep sensory ataxia as the local symptom analysis for this patient. And there was also some motor weakness and distal wasting. So LMN type of symptom was also there. So for that, whether it is an anterior on-cell, whether it is a motor nerve or muscle, that I would like to see. And there were some involuntary movement in the form of upper limb, lower limb, and orofacial movements, which had aggravated in the dark and closing the eyes. So on a background history of this sensory ataxia, I would like to check whether it is a pseudoethitotic pattern, or if it is a per se basal ganglia and its connection involvement. And for the dysphagia, I would like to rule out the bulbar part. So
Siddharth,
yes,
Siddharth,
sir.
just go back to the previous slide. So on the basis of all of the symptom analysis that you've done, you think that the patient predominantly has a sensory ataxia with some motor deficit.
Yes,
So
sir.
people are likely to ask, since you have also commented that when the patient was reaching an object, there were some tremors, there was overshooting and undershooting. Would you want to bring in cerebellar ataxia or spinocerebellar involvement as well? Or would you think that only pure sensory ataxia can explain all of those findings?
Sir, cerebellar could be one of the possibility in this case, but since the patient had a predominant clinical phenotype of a sensory ataxia, kind of the ataxia which was favoring more of sensory, I would like to comment it after the examination, because there would be contamination if the patient is having this much severity of sensory ataxia. But I would like to keep it open as well. which I would like to confirm it on examination, because this sensory ataxia predominant that the features had started, cerebellar may or may not be there, which may contaminate in this case. So I would like to keep it open and
Correct. And
like
you
to
should
comment
also
after
add,
exam.
since the patient was that severity of the sensory ataxia, that the patient was ataxic even when the patient was seated.
Yes, sir.
So severe sensory ataxia can mimic a cerebellar component. So as you rightly said, that can be confirmed on examination. Please go ahead.
So may I ask one more question?
Yes, ma'am.
So this patient had a sensory plus a motor problem. So why are we not considering a polyneuropathy or a radicular neuropathy in this patient?
Ma'am, for that I have kept a motor nerve as one of the feature in this case, and also the dorsal root ganglia. So that component I have kept it in the sensory and as well as in the weakness part. So for that I have kept the neuropathy component.
So, but there are a few points which tells you that it is not a straightforward CIDP. So would you be able to tell those points?
Ma'am, first of all, it was basically having features of both small and large fiber involvement. And also there was early and predominant sensory ataxia as the feature as compared to the weakness part. So usually the CIDP patients have a relapsing or remitting or a progressive disease where they have sensory motor weakness as their predominant symptom as compared to the sensory ataxia. They have subtle sensory ataxia as well due to the large fiber involvement. But in this case, the weakness part was more of a mild part, which had later come into the clinical course. All the clinical course started with a sensory predominant symptoms in the form of both small fiber involvement or whether it was a sensory ataxia predominant symptom, which further localization I would like to keep after the examination. So the motor nerve and neuropathy part is also being kept in the differential, ma'am. And the odd points against the CIDP was that the weakness was not predominant symptom that he had presented with.
I agree with the thing is a typical CIDP would have a weakness dominant presentation, but there can be variants where you can have ataxia as a dominant.
Yes,
but the upper limb ataxia is extremely unusual. Burning paresthesias can be there, but they are less common compared to the tingling paresthesias or pinceaural paresthesias. And here again, the perioral dyskinesias are extremely uncommon for a pure neuropathic syndrome, except unless they involve the anterior horns. So all of these are, and again, wasting was also very, very prominent and early on in the disease. So these make you suspect it is not a straightforward CIDP. Good, please go on.
So for syndromic diagnosis, I had kept as sensory ataxia with sensory motor neuropathy, which was length independent because it started with upper limb and it was proximal predominant more than distal with chorioathetoid movements, query pseudoathetosis, although I would like to confirm whether it was a true movement disorder or not, with bulbar involvement and systemic features of significant weight loss on a background history of significant smoking index of 120, that is chronic smoker. So for the localization, I had kept sensory ataxia, where three possible localization I had kept. One was the dorsal root ganglia. Second was the peripheral motor sensory motor nerve, and third was the dorsal column in the same order. And the justification for this is that for the dorsal root ganglia, it was a sensory predominant kind of syndrome that this patient had presented. And then it was a disabling type of sensory ataxia. Even in sitting position, he was not able to maintain his erect posture. So for that significant sensory ataxia, it is possible in dorsal root ganglia. Although in examination, I would like to confirm the other findings like reflexes and presence of symmetry or not, because on the basis of history, the symmetricity was not clear. And the second localization I would like to keep is the large fiber motor nerve, which is the peripheral nerve neuropathy, because it was a sensory motor kind of thing, sensory more than motor. And again, the symmetricity based on the examination and reflexes, I would like to check in after the examination. Dorsal column, I would not like to keep just for the completion of the list I had kept, but this patient did not have any human features because his weakness was also having a flabby nature with wasting. And reflexes, I would like to confirm in the examination before commenting, but there was no sensory level as well. And also the motor weakness was not that predominant. So this I would like to keep down the list. And
You
second,
also said you also said that the patient had flabby limbs, right? So that
yes, sir.
also
Yes.
points
So that
toward-
also
So
favors
those-
against the cord involvement. And second possibility, as sir had pointed out earlier, whether it could be a cerebellar ataxia also, or it could be a mixed, or it could be a contamination per se. So I would like, if this patient had presented similarly, so I would like to keep both axial and appendicular, because he has limb predominant ataxia and also the gait imbalance that he had. But there were many like pointers against cerebellar, like it was aggravated in the dark and he had a high steppage, looking at the feet, cautious type of gait. So, but still, I would like to keep it open and consider cerebellar involvement as well. And if at all cerebellar, then both hemisphere and vermis. So these are the differences based on the history and examination between sensory and cerebellar, which I would like to confirm after examination. And third localization, which I made, as ma'am was pointing out, whether it could be a neuropathy. So sensory motor neuropathy in a length independent manner also I had considered, which was pointers favoring where proximal more than distal, upper limb followed by lower limb. And in that also I would like to keep dorsal root ganglia, peripheral nerve, and if at all nerve, then the pattern fits more into a demyelinating type of neuropathy. And bulbar involvement would localize to the lower cranial nerve and the brainstem, which I would like to confirm. Before showing the examination, I would like to consider the possibilities, which should I discuss now, or after the examination should I discuss the possibilities?
So among the possibilities which you have mentioned in localization, is there a single one which can explain everything?
Ma'am, among the possibilities, single localization can be made. Either it could be a autoimmune etiology where Sjogren's can fit all, like it can fit the sensory motor neuropathy, dorsal root ganglion. And the second possibility could be a paraneoplastic disorder, which can fit all the findings, because there are multi-axial involvement in the neuraxis, with involvement of both peripheral nerve, dorsal root ganglion, and if at all cerebellar, if I consider it.
So the thing is that dorsal root ganglion alone is unlikely to explain everything, but you have
Yes.
to be careful in the history to see whether weakness is, the sensory problem is masquerading the weakness. This patient cannot do a lot of things because of severe sensory
Yes, ma'am.
attacks. They may say that it is weakness. Now, how do you explain the bulbar involvement with either of your possibilities?
Ma'am, again, bulbar involvement, I had kept as the either a possibility of the lower cranial nerve nuclei, or it could be the brainstem itself, in which basically, if at all I would like to connect all the things, it could the bulbar involvement predominantly points towards whether we are dealing with some structural lesion or any metastatic lesion or any paraneoplastic syndrome, because that thing was one thing which predominated to involve the multi-axial system, because it was more of a localization in the dorsal root ganglion and peripheral nerve region, but this bulbar involvement led me to think whether it is a multi-axial system or not. And also the cerebellar findings, whether I would like to consider it or not based on the examination.
And sometimes in Sjogren's syndrome, the dryness of mouth can be so much that they may have difficulty swallowing. So
Yes,
if since it stands out from the rest of the symptoms, it may be good to examine that part as well. Thank you. I think we can discuss this at the end of examination if Ayush is okay with that.
okay. So for examination, he was conscious oriented. He was basically having diffuse cachexia with generalized wasting of the cheek, thighs, hands, arms, and his vitals were stable. There was no postural drop. General physical examination, there was no cyanosis clubbing lymphadenopathy. There was no nerve thickening, no hypopigmented patch. Respiratory, cardiovascular, and per abdominal was normal. He scored full points in MMSC. His visual acuity was normal, and also the fundus examination was normal. His extraocular movements were fine. There was no ptosis, and his trigeminal nerve examination, he had normal sensation in face, corneal reflexes was present, and jaw jerk was not exaggerated. Seventh cranial.
So that you should emphasize there in the extraocular movement, since there was no nystagmus that you found there, that is something that is telling you that cerebellar is most likely to be normal.
Yes, sir. Also, for the eighth cranial nerve, it was normal. Gag reflex was weakly present. Uvula was although central. 11th and 12th cranial nerve was normal. Coming to the motor examination, apart from the generalized wasting and also the small muscles of hand were also wasted, but there was no preferential atrophy. The tone was reduced in all the four limbs, and the power examination in the upper limb, for the shoulder it was 4 plus, for the elbow it was full, for the wrist it was again 4 plus. It was not a significant kind of weakness. Hand grip was weak, and there was some asymmetry. And in the lower limb, power was proximally it was 4 plus, and distally it was full. But the reflexes of this patient was not present even on maneuvers, and plantars was bilateral flexor. And in the sensory examination, basically he had the pain touch temperature sensation, which was affected by around 20 to 30% in both the distal upper and lower limb. And for the joint position and vibration, the joint position, there was some asymmetry where the right upper limb, it was lost completely up till the shoulder, and in the left it was in the distal fingers and the MCP joint. And the lower limb, it was in the distal part, and it was symmetrical, which was lost up to the level of the ankle. And vibration, there was decay present in both the upper and lower limb, in upper limb till the elbow, in lower limb till the anterior superior iliac spine. Romberg's, it was not able to assess because he had a significant imbalance and he was not able to stand up. For the cerebellar examination, which I did, the finger nose and finger nose finger both was abnormal on both the sides, although there was right more than left, which I will show. There was no bradykinesia rigidity, and there was pseudoetheroid movements present both in the distal part of the hands, lower limbs. Also, there was oromandibular movement which was present.
Show that with the video only, because it will make more sense when you play the video.
So this was the patient, and he was asked to outstretch his both the hands. And we can see after closing the eyes, these random flow-like movements, which are predominantly distal, and it is involving both upper and lower limb. And there is subtle asymmetry which is there, which is more on the right as compared to the left in the upper limb. And we can also see in this video that his face, if we look at the face also, he is having some subtle movement of the both the lower part of the face, the cheeks and the chin part, which is having some random movement, which are basically aggravated on closing the eyes as well. So these are the lower face movement which the patient was having.
You should also talk about the feet. You can see that the feet are also tending to flap. That's also something that's quite unusual.
So it was both in the upper and lower limb, and we can see the feet as well.
And all the findings are more prominent on the right side. So there is prominent asymmetry. If you look at the right hand compared to the left, you'll see that the left hand is tending to stay a little straight, but the right is continuously moving like a piano. And on the right foot also, it's tending to flap a little more than the left foot. The face ones you've explained. We can play the next video.
So this was the focus movement of the face, although it was predominant in the first video as well, where he had some lower face random movements, which was basically seen even on closing the eyes, which was prominent. And it was involuntary only because he was not doing it on his own.
I have a comment here. The perioral movements, we need not look at eye closure here. I mean, except if, to distract the patient. We can ask him to close their eyes and do some arithmetic or something. That may make it prominent, but it is just the visual input is taken away. That is the purpose of eye movement, eye being closed. So that does not work on the face.
Okay, ma'am.
So you have nicely demonstrated the upper limb and lower limb athetosis being worsened after the eye closure, but it does not really apply to the face.
Okay, ma'am. So the cerebellar system examination which I did, actually, I felt that it was impaired. He had subtle overshoot as well in some of the motions, and the trajectory was also not a straightforward one. But he had a significant kind of sensory ataxia. So to consider this as the cerebellar ataxia or not is I would like to support it by other features, since he did not have any nystagmus. But although this appendicular can be seen even without nystagmus, so I would like to keep it open in this case, because if I play the video again, he was having this whole trajectory, and even the target, when he had reached the target also, there was errors. I would like to keep it open, whether we can say and keep it as a cerebellar syndrome as well, on a background of sensory syndrome. So he also had some intention tremor on reaching the target.
Maybe we should stick to the rule of parsimony here, because this severe sensory attacks is sufficient to explain the ingestion tremor. You need the sensory inputs for the cerebellar system to work properly. This severe sensory attacks may not be even compensated by vision. So if we stick to the fact that we can take the least number, that will help us formulate a larger differential diagnosis.
Okay.
Rather variety of it.
So after examination, what we had added is that he was having sensory ataxia. He was also having large fiber neuropathy with some mild weakness, and also significant asymmetry was there, which was more on the right as compared to the left. And I had put a question mark whether cerebellar ataxia, but as the discussion in the severe sensory ataxia, we are not very sure to take this as in cerebellar ataxia. So the localization after the examination, since there was a asymmetry, so I had made dorsal root ganglion as my first, and also there was some motor weakness which also had some wasting in it. So I would like to keep peripheral nerve as well, because to combine both the things, the dorsal root ganglia and the proximal peripheral nerve, the motor root, which can be affected in the systemic syndrome. So coming to the possibilities, I had considered autoimmune. So in this predominant sensory ataxia, I would like to rule out.
Now, based on what you discussed after the examination, would you like to shortlist from your possibilities as to the 3 most likely possibilities that you're considering before you start investigating?
Sir, the 3 most likely, one, I would like to consider Sjogren's in autoimmune category. Second, I would like to consider the paraneoplastic sensory ataxia category.
Right.
Although he did not have any toxin or any exposure, but still I would like to keep it open because he received some Ayurvedic drugs as well. So pyridoxine is toxicity is known to cause this type of syndrome.
Correct. So just go back. So you can say that it is unlikely to be nutritional and neuroinfections, because they will usually present with the symmetricity of findings. Like that gross asymmetry indicates that it is not B12 deficiency or copper deficiency or HIV, neurosyphilis, because all of those are very symmetric, usually speaking. Vasculitis, the patient did not have painful involvement to begin with. So you can say that although asymmetricity can be seen in vasculitic neuropathies, that is also unlikely. You can go on.
And for CIDP, again, it was very odd. And CISP, it was not a pure sensory. There was some motor involvement as well.
So I just add that since there was a question with regards to this, that why can't it be CISP by Dr. Ocean? So since the fact that the patient also had a motor deficit, CISP becomes highly unlikely. Yeah.
And again, the new entity which is coming up is the paranodopathy, nodopathy spectrum. Although less likely in this elderly age group, but still, if I narrow it down in paranodopathy spectrum, contactin 1 can produce this predominant sensory ataxia type of syndrome with associated motor weakness as well. And the rest of the things like Sando, there was no ophthalmoparesis, so I would not like to consider. And Canomad also, there was no ophthalmoplegia. And Canvas, the vestibular examination was predominantly normal, and it was not a predominant cerebellar ataxia type of syndrome. It was just a mimicker to consider it. And again, he had some sensory paresthesias and burning and tingling. So Fabry's, but Fabry's does not cause significant sensory ataxia. So these
So-
are lower down the list. The
So
top
you're left with autoimmune, paraneoplastic, and probably toxins, right?
Yes.
Okay.
One
So-
more doubt, Siddhartha.
Yes, ma'am.
The perioral movements which you saw,
Yes, ma'am.
is it possible to describe that with a neuromuscular syndrome?
Ma'am, with the neuromuscular syndrome, it can be seen in Kennedy's disease, where the lower face and orofacial predominant dyskinesias are there. But this patient had a predominant sensory syndrome. And
Consideration here. Yeah.
so we are not bringing, although he had wasting and motor weakness was there, but predominantly all the syndrome was fitting into a sensory predominant more than motor. And apart from that, ma'am, paraneoplastic neuromuscular disease like Lambert-Eaton syndrome sometimes can mimic this perioral movement predominantly in the tongue, but they are not producing this perioral movement. They are in the predominantly in the tongue, which can be seen. And so, so the neuromuscular.
Casper 2 can produce it. Casper
Casper
2,
yes,
that choric movements because of the that myokymia, and
myokymia.
yeah, it can look like choric movements. That would be worthwhile checking. Multiple antibodies can coexist, or multiple autoimmune diseases can coexist.
So in the routine blood investigations, his complete blood count, liver function test, kidney function test, and the nutritional levels in the B12 folate were all normal. And his viral marker was negative, and his immunoglobulin levels were normal. His thyroid function test was normal, and the autoimmune panel, ANA, ANCA, APLA, and ENA, where the Sjogren's profile was also done, which was negative. And also the serum protein electrophoresis done in the view of also suspected CIDP and CISF. It was normal. There was no M bands. Sarcoidosis workup, the ACE levels and 24-hour urine calcium was normal. For the paranodopathy, nodopathy spectrum, we are screening with urine albumin creat ratio and 24-hour urine protein. So that was also normal in this case. And finally, the toxin panel that we had sent, there was no abnormal toxin detected both in the serum and as well as in the urine. And then the CSF analysis was done to look whether inflammatory conditions can be favored. So cells were nil and protein sugar was also normal, and all the infective parameters were negative. Shermer's test was also done because there was a strong possibility of Sjogren's in this case, and it came out to be negative as well. So then the electrophysiological study in the form of nerve conduction test was done, which revealed both the sensory and motor polyneuropathy, but sensory more than motor, and there was demyelinating pattern which was seen. And then needle EMG was also done, and it was normal. The surface EMG was also done, which did not show any. It was done in the form of severe wasting and weakness, so it was normal. There was no abnormal movement detected. Imaging also did not show any specific abnormality. So then the workup for paraneoplastic was screened, and the ultrasound, scrotum, kidney, thyroid, all were done, which was normal. Even in a background of chronic smoker, the lung cancer screen was done with the CECT chest, which was normal. But since we had a suspicion of a elderly male with smoking index of 120 and this syndrome, so for paraneoplastic etiology, we had targeted the PET was done for whole body, which was not suggestive of any abnormal uptake. And even we did the EBUS guided lymph node biopsy, which did not show any evidence of malignancy. This is the nerve conduction study. One thing I want to highlight is that this patient had a sensory nerve conduction. All the upper and lower limb were not recordable. But we see the motor conduction, it was also affected in the form of right peroneal nerve, left peroneal, and bilateral tibial. And to note is that the latency was more than the 150% cutoff with a amplitude which was less than 50%. And also the conduction velocity was also reduced. but the distal latency was much more prolonged. So that is why we had considered demyelinating more than axonal. And also there was involvement of motor as well. So this was a screening X-ray that we did. It was not suggestive of any like any space occupying lesion or parenchymal lesion or any abnormal lymphadenopathy. The PET whole body also did not show any abnormal uptake, the whole body and also the brain. This was the serial MRI imaging which was done, which was again non-revealing in this case, and there was no cord changes found in this case. And so what next? Because we had almost investigated all the possibilities that we had considered in the form of autoimmune, paraneoplastic, toxin, and other features in the form of nodopathy, paranodopathy, CIDP, CISF spectrum as well. So if at all any what would be the next investigation? So then we went with the paraneoplastic panel. So to our surprise, we noted that the paraneoplastic panel had showed a triple positive, strongly positive antibody index. It was done in a serum sample, and we had found anti-HU, which was strongly positive, anti-CRMP5, which was strongly positive, and anti-ampifysin, which was also strongly detected. So all three antibodies were detected in a very high titer on the serum. So then we had given him the treatment in the form of paraneoplastic sensory ataxia with sensory motor polyneuropathy. We had started him on pulse MPS, 5 cycles of plasmapheresis, and also we had given him rituximab induction therapy and maintenance dose. So basically coming to the end of this case opened up to review the paraneoplastic syndromes. So initially it was described in 2004, where these 6 antibodies where the onconeural antibodies categorization was given, out of which this patient had anti-HU, CRMP5 and anti-ampifysin, all three. And this underlined thing was the classical paraneoplastic syndrome, which they had kept, and our patient had this sensory neuronopathy kind of picture. And for the diagnostic criteria, in our patient, this patient had a classical neurological syndrome with positive onconeural antibodies, and for the extensive malignancy screen, it was not possible. So it was not found. So he fitted into the diagnostic criteria, but currently in 2021, the diagnostic criteria has been updated, and they have identified some high-risk phenotypes of the paraneoplastic syndromes, and there are 7 high-risk phenotypes, out of which our patient had the sensory neuronopathy syndrome. And they are telling that the definition wise, it can affect any part of the nervous system. It occurs association with the cancer and has a immune mediated pathogenesis mediated by some neuronal antibodies. So when we reviewed this case, we found that our patient had a sensory neuronopathy. And the interesting thing is that we calculated the sensory neuronopathy score in this patient. And this patient had a score of 12.7. So according to the criteria, if it is more than 6.5, then the patient fits into the sensory neuronopathy spectrum. So what he had is that he had ataxia, he had asymmetrical distribution, he had sensory loss, he had also the abnormal nerve conduction study in both sensory and as well as the motor findings. And the important thing to note is that they have specifically mentioned that paraneoplastic origin should be considered if the patient have inflammatory CSF findings or motor involvement. So in accordance to the sensory neuropathy, if we find the inflammatory CSF or a motor involvement, then the paraneoplastic suspicion should be high on the list. And the antibodies which are most commonly implicated is anti-HU followed by CRMP5 followed by ampifysin. So our patient had all the 3 antibodies positive in this case and fitted into this paraneoplastic syndrome. So again, this is the differentials of the sensory neuronopathies, where paraneoplastic was one of the etiology which the patient had, and it had progressed with the subacute chronic. So this patient had a 2-year history which was chronic, and then for the etiology there are multiple cancers which we had to rule out. and we did it with extensive investigation, but it was not possible found. So these are the high risk antibodies. Again, we can see that the 3 antibodies that the patient had all were fitting into the high risk, and the latest 2021 criteria has delineated the antibodies according to the risk stratification, where the high risk is if it is more than 70% association with the cancer. And we can see that all the 3 antibodies, the small cell lung carcinoma are the tumors which is having the maximum association of, if we can see the percentage, it is almost more than 80 in all the 3. So for the SCLC, we had screened with the PET, and also we did the IBUS guided biopsy. We did not find. So this is just to complete the list, the intermediate risk antibody, which is 30 to 70% according to the criteria.
We can skip that because we are running short of time for the second case. So we can just highlight what is important here.
So this is for the recommendation. So if the patient is having PET negative and no malignancy is detected, screening criteria is every 6 months for 4 years, because we know that paraneoplastic may precede the actual malignancy in 2/3 of the cases. And for the response with immunotherapy, they have told that the cell surface antibody are more immunotherapy responsive, because they are predominantly involved in the direct neurotoxic effect as well. So one thing to highlight, just want to tell about this score which has newly been created, PNS care score. So this is based on the clinical criteria, the antibody titers, and if the presence of cancer is there or not. So our patient had a high risk clinical phenotype, 3 points, high risk antibody, 3 points, and the cancer was not found, but the follow-up of less than 2 years is there. We will follow him up. So 1 point. So total of 7 points were given, and he was fitting into the category of probable paraneoplastic syndrome. So the learning point is that sensory ataxia has to be identified. Look for signs of pseudoathetosis, and screening for paraneoplastic syndrome should be done if the patient is having risk factors, particularly in elderly patients. Sensory ataxia, cerebral ataxia with neuropathy, predominantly motor, should raise our alarm for a paraneoplastic clinical phenotype, because there are multi-axial involvement. So, and there is a care score which is newly devised. We can calculate the care score based on the high risk clinical phenotype, high risk onconeural antibody, to characterize the risk of PN syndrome. And prompt treatment of underlying malignancy is the first line. And if we are not detecting the malignancy, then it should be followed for at least a period of 4 years before labeling the patient as malignancy free. And we can treat the patient with immunotherapy in these cases. Thank you.
Thank you, Siddharth. Thank you for that good presentation. I'd just like to add that this was the first patient that we have seen that who was triple positive for paraneoplastic antibodies. We've never seen that before. And 1 year into the illness, we've repeated a PET, but still not found anything on the PET to come up yet. And the patient has improved from being completely bedbound to walking with 1% support right now.
Yes.
So that is the present follow-up.
Thank you, Dr. Siddharth and Dr. Ayush, sir, for the exhaustive review of literature and the informative case. Thank you, Shruti, madam, for the inputs. So we have few questions. We can quickly recapitulate where to localize the bulbar symptoms in this case. Where would be the clinical localization? Would you like to answer that, Dr. Siddharth?
So for the bulbar symptom, on clinical examination, the gag was although weakly present, and uvula was central. So for that, the screening of the brainstem was also normal. So the paraneoplastic syndrome is bound to produce some amount of bulbar symptom as well, because there are multiple phenotypes. Only I have discussed the high risk clinical syndrome, but there are also low risk syndrome where involvement of the brainstem, which may not be apparent on the imaging, might be a hider in this case. And since he did not have any significant dry mouth or per se
Right.
that involvement, so probably the paraneoplastic syndrome is that we have kept as a cause of the bulbar symptom.
That one point, great case. You may need to do an ogeriscopy if it is not done yet. Ogeriscopy, colonoscopy, because that may bring out some missed malignancies.
Yes, ma'am.
Especially because bulbar is not easily explained. I mean, we don't have an MRI evidence for a brainstem patient.
All right, ma'am, we'll do that.
Thank you. Devyani ma'am, shall we proceed to the second case?
Yeah. Just one more question that has come up, and I think that the younger residents might be wanting to know this. So, Siddharth, can you just recapitulate quickly the clinical points that favor the ganglionopathy, dorsal root ganglionopathy?
Clinical points was one is severe sensory ataxia, one is asymmetry, one is absence of deep tendon reflexes, and these three are the predominant thing based on the clinical findings of history and examination. Then, if we look the nerve conduction study, DRG would have a only sensory nerve conduction abnormality. The motor will be normal in DRGs. So that is one point which we can differentiate it with the peripheral nerve.
Okay, thank you.
The nerve conduction study which you showed, if you can quickly go back there. Here, the demyelination here is not conclusive.
Yes, ma'am.
Because wherever you're finding demyelination, there is significant axon loss. It is less than 50% of the upper limit of normal amplitudes.
Yes, ma'am.
You need to apply more stricter criteria to be.
Yes,
sure
ma'am. That
about
is
the
why only in tibial, left tibial, it was fitting, and there were both the pattern which was fitting. The velocity was not exactly favoring the demyelination. The latency of 150% with a less than 50% amplitude was favoring in one. So it was not completely fitting into a demyelinating. So that's why it kept as a demyelinating more than axonal. So I kept it open. So we did EMG to see if there are any.
I would say that it is axon more than demyelinating.
Yes, ma'am.
Thank you, anyway. We had one case with more Casper to an NMDA positive, but none with so many paraneoplastic antibodies.
I think the presence of the lower facial dyskinesias was fairly striking in this patient, and I think that's a nice learning point. So I think that Shresi, I think you can invite the next presentation.
Yes, so I would like to invite Dr. Abdul Kavi, who is going to moderate the case, and Dr. Rohit, who is going to present our second case. Please take over, Dr. Rohit.
Hello. Yeah, am I audible?
Yes. Yes, you're audible.
Should I start now?
Yes, please.
Okay. So, good afternoon, everyone. So, I'm going to present a case of a young girl with a brainstem syndrome. So, this was a 15-year-old Hindu female, was a resident of Sitapur, UP, and class 11 student. And the informant was the patient herself, and history is reliable. So, this patient came to us with chief complaints of fever 2.5 months back, imbalance while walking 2.5 months back, and worsening since 13 days, history of hearing difficulties, and right-sided facial deviation since 2.5 months, vomiting since 2 months back, and with recent worsening 15 days back, double vision since 2 months, and difficulty in swallowing since 2 months. So the patient was apparently asymptomatic until 2.5 months back, when she had a febrile illness that lasted around 2 to 3 days back, 2 to 3 days, and she had high-grade fevers with no other accompaniments. Next, 4 days after the febrile illness, she reported that she had difficulty in walking, which was acute in onset, and there was swaying to either side, more towards the left. And she reported difficulty in navigating narrow passages and crowded places. There was history of intermittent giddiness as well and postural variation. However, there was no history of any falls or worsening of these complaints in the dark, or any history suggestive of wasp-basing phenomenon, or any difficulty walking on uneven surfaces. Following the imbalance, she also noticed simultaneous decreased hearing in her left ear, which was acute in onset. However, there was no local ear pain, tinnitus, or oral fullness. She also noticed 1 to 2 days after these complaints that she had right-sided facial deviation, and that she had drooling of saliva and feeds from her left angle of mouth. There was inability to completely close the left eye during sleep. And she also noticed decreased taste sensation on her left side. 2 months back, around 20 days after the febrile illness, She had severe vomiting bouts, and these were sudden in onset. The duration lasted around 2 days, and these were non-projectile watery vomiting. There was no relation with meals, and these were minimally responsive or almost refractory to medicines, whether there was oral or injectables. These were also accompanied. These vomiting episodes happened once 2 months back, and this imbalance in walking also happened 2 months back. And there was a similar illness that was presented around 15 to 13 days back. And both of these episodes had refractory vomiting and imbalance in walking. In the current episode, she also had hiccups that lasted a day. And when the episode happened 2 months back, she took treatment with some injectables. And following that, she noticed that she had developed some posturing and deviation of neck to right side with uprolled eyeballs. However, this lasted only over a day and it resolved spontaneously. After the vomiting episode subsided, she noticed double vision, and this was present more with both eyes open, and it was better on closing her right eye. This was worse for far, and there were two side-by-side images, and mother also noticed slight in-turning of left eye. For these complaints, she consulted an ophthalmologist who prescribed her spectacles, but she showed no improvement. She also noticed in the same time that she had difficulty in swallowing since 2 months, which is more for solids than liquids. And she noticed difficulty in passage of foods after chewing. And there was also decreased salivation. However, there was no obvious nasal regurgitation or pain during swallowing it. There was so all of these complaints happened around 2 months back. A cluster of symptoms happened around 2 months back. She underwent treatment for the same, noticed improvement in some of those complaints, and 15 days back she had a recurrence of few of those symptoms for which she came to us. And along with the old complaints, this time she had a history of drooping of left eyelid since 1 day prior to the admission. And there was no diurnal variability, and there was no history suggestive of decreased sweating over the face or blurred vision. She also reported intermittent biting of tongue on the left side while she was chewing her food. There was no history of any headache, aggravation of complaints with neck movements or neck stiffness. There was no history of proximal or distal upper limb or weakness or sensory loss, no bladder bowel complaints or autonomic complaints, no cognitive decline, behavioral abnormalities, seizure or loss of consciousness. There was no history of memory or attention disturbances, visuospatial difficulties, executive dysfunction, language deficits or extrapyramidal abnormalities, no drug or toxin exposure, or no tremulousness of upper or lower limbs. There was a background history of intermittent multiple joint pain since 5 to 6 months, with small joints predominant, and there was morning stiffness. Otherwise, the past medical history was non-significant. Personal history and family history was also normal. So for all these complaints, as I told, she had 2 episodes, and she consulted a local doctor who prescribed her pulse steroids and antivirals 2 months back, and some of their symptoms started showing improvement 10 days after starting the pulse steroid. Most of her symptoms showed resolution. However, she reported persistent mild ataxia of gait, blurring of vision, and dysphagia, and was continued on oral steroids with tapering. Some of these symptoms had actually worsened after the steroid taper in the current illness episode. There was no history of any recent vaccinations or toxin exposure. So,
explain what were the symptoms which were present in the earlier phase and in the second time.
Yes, sir.
There were any new symptoms or the same symptoms worsening?
Sir, actually, initially she reported symptoms of, like, it started with a febrile illness. Following that, she had imbalance in walking, and then subsequently she reported difficulty hearing and facial deviation and vomiting. These were the main complaints that happened in the first illness. This and double vision was also there. This time she reported only a 15 days back episode of a febrile vomiting episode, and she subsequently noted the imbalance in walking, which has initially improved. This worsened since the last 15 days. And this time new complaints were hiccups that were not responding to the local therapy she tried at home. And apart from that, she had also noticed that there was a drooping of left eyelid. Other than that, so these were the 4 main complaints which she presented to us.
Okay, go ahead.
Yes, sir. So coming to summarize the case, so this was a 15-year-old female with 3-month duration of subacute onset asymmetric cerebellar ataxia with multiple cranial nerve involvement with recent worsening, however, without bladder bowel or autonomic disturbance on a background of febrile illness with refractory vomiting. So coming to the functional neurological deficit, it's mainly an asymmetric onset cerebellar ataxia with multiple cranial nerve involvement. I will localize the lesion, the ataxia mainly to the cerebellum and its connections, and the cranial nerve involvement in the brainstem nuclei or its fascicular course. Right now, I wouldn't be able to differentiate between the nuclei or the fascicular course because based on history, so far I haven't got much clues to that on whether or not I can differentiate it, whether it's a nuclear course or a fascicular course. And etiological wise, because there are two definite illness and there is intermittent fever and vomiting episodes, I like to keep Roman encephalitis high up on the list. And in that, considering our clinical scenario, most common infective causes I would like to rule out, like TB, JEHSV, and autoimmune causes like Behçet's. Demyelinating illness, because there are two definite episodes here and which showed improvement with steroids. So yes, I like to keep demyelinating like MS, NMO, and MOG. There is also possibility because this is a young female with history of joint pains and presenting to us with lower brainstem features. I would like to keep the possibility of vasculitis and also, although there was no history or so far, but I would like to keep the possibility of CVJ or dissection leading to vertebrobasilar insufficiency.
Dr. Rohit, I have a few questions.
Yes, ma'am.
Based on your history, which parts of brainstem were affected?
Yes, ma'am. Ma'am, initially the first complaint, like she started noticing that there was an imbalance in walking, and it was more of a swaying to either side. Ma'am, that swaying could have, and because there was that swaying could be because of three pathologies. It could be a cerebellar in origin, or a vestibular, or a sensory origin. However, because there was no worsening in the dark or abdominal, no stamping gait-like feature that she described. So sensory, I would like to keep less likely. Among vestibular and cerebellar, because she had vomiting, but there were only 2 episodes. At this point, it's difficult to say whether or not the vestibular component is predominating or not, but there is little sway. So I'd like to keep possibility whether involvement of the cerebellum and its connection is also possible. And the vestibular nuclei, because of the involvement of significant vomiting episodes are there. So I'd like to keep the possibility of vestibular nuclei also in, and it's the vestibular apparatus is also possible in this case.
The lack of vertigo or oscillopsia is also a point which goes against
Yeah.
the vestibular involvement.
Yes, ma'am.
And the next
the next part, ma'am, the other cranial nerves involved subsequently the right-sided facial, like it looks like element 7 palsy, and also there is a decreased hearing component, and she also has dysphagia. So the other features looks like a lower cranial nerve involvement, and along with it there is a drooping of left eyelid, and also there is a feature of double vision, which looks like a lateral rectus or a right medial rectus palsy that we'll have to see on the examination. There is a diplopia which is worse for far. So there was a history. So there was possible involvement of 6 cranial nerve as well, and also the involvement of cranial nerve 3, or it could be a involvement. The ptosis could be due to a sympathetic pathway. We'll have to see for other features for that to say conclusively why the drooping of the left eyelid happened. So, so far now, ma'am, I think because the involvement of the lower cranial nerves, it looks that the medulla is definitely involved. And because of the ataxia feature, I would like to keep the area cerebellum and its connections. And for the midbrain involvement or not, or whether it's due to a sympathetic pathway ptosis, we'll have to see that on examination to see whether midbrain is involved or not.
I agree with you. The pons is definitely, if it's an interaxillation,
Yes,
pons is definitely affected because there is a 7th cranial nerve or fascicle and
Yes,
the cochlear nuclei.
Yes, ma'am.
And area postroma is also possibly affected because
Yes,
that
yes,
indicates medullary involvement, and dysphagia is also there.
Yes, ma'am.
As you told, the ptosis could be within the pons itself or
Yes, ma'am.
medullates.
Yes, ma'am.
One more question. She had 1-day history of uprolling of eyeballs.
Yes, ma'am.
And the
Actually,
tongue bite. What do you make of it?
Actually, that day, ma'am, she did not report it. A tongue bite was intermittent while chewing the food. In that episode, what actually she reported was after she was given injectables for the multiple episodes of vomiting, she noticed that only for one day, and that symptom resolved. So I considered a few possibilities because in the context of other features, the other cranial nerve involved, I was initially confused whether this was a because she reported that her head used to turn to the right and she had eyeballs turned towards the upside. So because of the other cranial nerve involved, I quickly jumped to the conclusion whether it was a SCM weakness or as such that unilateral sternocleidomastoid was weak also. But then I thought that because of the weakness should have involved then or that of the right side only. So this could not be the possible cause because if the cranial nerve 11 would have involved on the same side, the neck should have been turned towards the left side. The next possibility I considered was because the injectables were given some antiemetics, so it was possible some kind of dystonic reaction, or dyskinesia or a dystonic reaction to some drugs that were given because it resolved spontaneously without giving any drug, and there were no treatment required for it. And because there was no loss of consciousness along with this, I would less likely keep a possibility of seizure or any accompaniment happening that time. So it looks more likely a kind of movement disorder associated with the drugs given for the vomiting.
It looks like an acute dystonic syndrome because eye
Yes.
movement is very typical of an oculogyric crisis.
Okay,
The
ma'am.
upward eye movement lasting for a very short period of time.
Yes, ma'am.
So then which medicine do you think may be responsible?
Yes, ma'am.
Which medicine is the usual culprit if it is vomiting?
Metoclopramide can be a possibility.
Very often that is a cause.
Yes, ma'am.
And finally, one more question. Why do you think the patient had recurrence of symptoms? After
Recurrence of symptoms, actually, ma'am, these all happened after the steroid tapering was continuing, and it almost nullified to almost she stopped the drugs in the last 3 to 4 days, and because her course had completed for the steroid taper, and I think the symptoms worsened post that only because for 3 days she was completely asymptomatic, and all her symptoms were improving after the pulse steroids were given, and even after the oral steroids were being continued. Immediately after the steroids were tapered and stopped since last 2 to 3 days, a few of her symptoms began to worsen, and some new symptoms also cropped up.
Do you think it's the same steroid-responsive disease which has worsened due to rapid steroid taper?
It looks like it primarily, ma'am, because the presentation was the first presentation. Also, what led her to attend to a doctor was the refractory nature of the vomiting, because it was almost 30 to 40 episodes happening over a day, and this episode also began with it. So, the first episode had a midway course of vomiting, and this episode began with a vomiting episode. And the first episode also had a beginning of complaints with the imbalance of walking, and this episode also had a similar beginning. And this time also the other features also are more suggestive of a lower cranial nerve involvement per se. So I think it is the primary illness only which is recurring back with the second episode.
Please go
Yes. Should I go ahead with the examination?
Yes.
So coming to general physical examination, it was normal. The BP, pulse rate, heart rate, and temperature was normal. On per abdominal examination, because of the vomiting, we thought of some abdominal causes. However, it was non-tender and there was no organomegaly. So the abdominal causes were ruled out here. The higher mental functions, the speech and language was normal. The first and second cranial nerves were grossly normal, except mildly decreased visual acuity of both eyes. And the third, fourth, and sixth cranial nerves in pupils of the left eye, we found it was slightly miotic. However, the direct and the indirect light reflex were normal. There was no RAPD or ciliospinal reflex. In ocular alignment, we found a mild skew deviation with left eye hypotropia. The saccades, pursuits, and VOR were normal. And there was an upbeat nystagmus with end gaze horizontal nystagmus. With this video, I will be showing towards the end after completing the examination. So the positive findings here are a miotic pupil with a skew deviation and upbeat nystagmus. The fifth cranial nerve examination was normal, and there was a left element 7 nerve palsy, and the tongue taste sensation was impaired on the left side, anterior 2/3. And the 8th cranial nerve examination was suggestive of a left SNHL. And the 9th, 10th, the parietal movements were decreased on the left side. The uvula was deviated to the right side, and gag reflex was also decreased, suggestive of a lower cranial nerve element type of 9th, 10th palsy. The 11th, the trapezius was normal. However, we noticed mild weakness of the left head turning. So possibly the 11th cranial nerve was also involved. And the 12th, the tongue was deviated to the left side, and there was decreased tone on the left side. However, there was no obvious wasting or fasciculations. The motor system examination was grossly normal. The power and all, upper limb, lower limb, all were normal. The superficial reflexes were all present with a flexor plantar. The reflexes, DTRs were also normal. On cerebellar examination, we found finger nose test to be impaired on the left side, and knee heel chain test also to be impaired on the left side. However, dysdiadokinesia, past pointing, and rebound sign were normal. The sensory components, the cortical and the peripheral sensation, both were normal. And in gait, only the tandem gait was impaired with swaying to either side, and with more on the left side than the right. I'll come to the video first. So this one is the ocular movement abnormalities. So if you'll notice, there is a slow coarse nystagmus, vertical nystagmus actually, with a slow downward and fast upward component. And this is super added with a horizontal component when she looks toward the right. And the pursuits looks okay. On the left horizontal gaze also, end gaze also, we found a super added horizontal component, which is actually not very clear in this video. And in the down gaze, there is no change in the vertical component. However, in the up gaze, the nystagmus seems to have slightly lessened. I'll just, should I repeat the video once more, or it's okay?
I think you can move on in the interest of time.
So as we showed, it's a slow, coarse, jerky nystagmus component with a vertical nystagmus. And it is on the right side, it has definitely worsened, which we think is being added by a horizontal component also, apart from the vertical nystagmus. The pursuits look okay. And on the left side also, there is only a mild super added horizontal nystagmus, which is being added. Down gaze seems to unaffect the vertical nystagmus. However, in the up gaze, looks slightly decreased as compared to in the primary gaze position. So based on this, we thought this is an upbeat nystagmus with a super added horizontal nystagmus, and this we localized it to the medulla and the cerebellum.
Generally, upbeat nystagmus increases with upward gaze.
Yes, actually, upbeat nystagmus, when there are two, if it increases in up gaze, then it localizes to cerebellum, and if it decreases in the up gaze, then it localizes to paramedian medulla.
Please.
Okay, and the next video, this one is the next video. You can see mild left genioglossus weakness, and the tongue is deviated to the left side. When we're doing a finger, I've just kept the positive findings. So in this, the finger nose test, we can see on the right side, she had no impairment. It's almost normal. While in this, we can see some degree of undershooting on the left side. Slight dysymmetry on the left side. While doing a dysdiadokinesia or the rapid alternating movements, it was almost normal. The heel chin was also impaired on the left side. While doing a tandem gait, you can see that there is swaying to either side. However, the sway increases when she places her left foot more so. So the tandem gait is also impaired. So based on these pathologies, so the positive findings, as I've already updated, we have found a left eye ptosis with meiosis. It is a skew deviation with left eye hypotropia, an upbeat nystagmus with a gaze evoked horizontal nystagmus, and the left element 7th and lower cranial nerve palsies with left-sided cerebellar signs. So based on this, we had a few investigations that she had done from outside during the first episode. In this, the MRI, the first MRI, the T1 section shows the in the dorsolateral region, medullary region, and the MCP region, we can find the hypodensities T1, and which do not show any contrast enhancement on the T1 section. In the T2, we'll also notice the similar sections which are hypointense in the dorsolateral regions, dorsal paramedian medulla, and which were they were hyperintense on here, and in the T2 flare, those lesions are hyperintense, and they show bright signal on DWI as well. This was from the first illness episode, after which she was given pulse steroids and antivirals from outside. Subsequently, when she got admitted here, this was the radiology investigations which was done. So we found still some hypodensities, and in the paramedian dorsolateral medulla region, which were hyper on T2 and flare, and this showed mild DWI bright signal in the paramedian region, and this showed no contrast enhancement. Higher up in the rostral medulla, we found also T1 hypointensities which were hyper, the dorsolateral, and also there is now some involvement of the ventral part, the lateral ventrolateral part of the medullary left medulla, and which are hyper on the flare section imaging as well. These show bright signal on DWI, and they show no contrast uptake. And this was the region of MCP, and this was possibly responsible for the ataxia. And this showed T1 hypo, T2 hyper signals, and this showed mild DWI bright signal, and there was no contrast uptake. So based on these radiological features, among other possibilities that we had kept, NMOSD came out to be the most highest up list, because this patient was almost satisfying the Wingerchuk criteria. So the first diagnosis which we kept based after seeing the radiology and the clinical scenario, NMOSD was kept first. This is one of the sagittal sections. So we can see some hyperintensities, and also this rules out effectively a CVJ that does not look like any tonsillar herniation or a atlantoaxial dislocation. So CVJ dedicated MRI scan could not be done in this, and is being followed up in the next episode. So the routine blood investigations were sent based on the radiological features. They were normal. The ESR and CRP were also normal. The ACE level, B12 thyroid profile was also normal. RA factor came out to be positive. ANA and vasculitis panel were negative. CSF showed sugar that was in the normal range, protein, mildly raised proteins with 60, and the cells were 25, and all were lymphocytes. The gene expert, the commonly cause, the TB, as I told, ruling out the cause as rhombencephalitis, it was negative. The MGIT cryptococcal were also negative. And the viral bacterial panel, including Listeria and enterovirus, they were also negative. CSF for OCB was also sent to rule out MS, and it was also negative. We first sent for NMO, and it was actually negative. And the next, subsequently, we sent for the MOG antibodies, which are strongly positive. So this actually led us to revise again the criteria for MOGAD criteria. So so coming to the latest diagnostic criteria, which has been given in 2023, International MOGAD criteria has been given in January. This was published in an article in Lancet. So among these, if you'll notice, actually, none of them have classically presented, whether there is a brainstem core clinical characteristics, we require one of the core clinical characteristics from this list. And our patient is characteristically fitting into the brainstem or cerebellar deficits. And with a clear positive, however, they did not give a titer in that. However, it was 4+, so we are considering it as a clear positive mock test. And so we do not require any additional supporting features. However, had it been a low positive and or a positive without titer, we'll need aquaporin seronegative also. So that also is there in our case. Aquaporin negative is there. And one supporting clinical feature is the middle cerebral peduncle ill-defined hyperintensities is supporting the diagnosis of MOGAD. Interestingly, if we just notice any patient presenting to it with a demyelination syndrome, and in the lesion being around dorsolateral, the medullary region, if the MRI, this is taken from this review article, and if you see the clinical MRI phenotype is consistent with MS, like whether it is CSF OCBs or a short segment hyperintensities or a Dawson finger, then we can lead the diagnosis to a MS. Now, although we say that aquaporin antibody is the next to be done in these cases, so it comes out positive, then the diagnostic criteria shifts to aquaporin positive NMOSD. Now, in NMOSD, although we say that 8 to 30% of patients of NMOSD will test negative for NMO, and out of those patients, around 10 to 40% patients will test positive for MOG. However, they have not kept any, there's a vacant lacuna, I think, because in these cases, those cases who have turned out to be aquaporin 4 negative, and in these cases, clinical scenario like this illness where it presents characteristically as a brainstem syndrome, and where that to a lower brainstem syndrome, the possibility of MOG was actually low on of our diagnosis. And however, if you see that if the MOG test is simply positive and the clinical MRI phenotype is consistent, we'll have to consider the possibility of MOGAD only. Because only if it's negative, then we can consider a possibility of seronegative NMOSD. And there are few red flags in NMOSD diagnosis. If these happen, we should review our diagnosis of NMOSD, a CSF cell count less than 5, a lack of improvement with immunotherapy, a progressive disease course, a short segment T2 lesions, a CSF OCB positive, lack of gadolinium enhancement or fever. Few of these red flags were also present in our patient as well. So just a brief literature review of 2 to 3 slides. So as I told, 10 to 30% of patients of NMO will test negative for aquaporin 4, and out of them 8 to 40 will test positive for MOGAD. And these MOG may not only be targeted secondarily in late stages of NMOSD, but they may also serve as autoantigens driving the immune response in NMOSD, particularly in the aquaporin 4 antibody negative patients. And dual antibody positivity is very rare, and that also aquaporin 4 titers will be high and MOG titers will be low. However, in our case, on the MOG titer is very high. Now, the odd point about MOG is because it is characteristically said to be targeting the oligodendrocytes, which covers the CNS system mainly. So this presence in the peripheral tissue is per se not expected. And thereby, I think why they have not yet involved the cranial neuropathy as a part of MOGAD, because oligodendrocyte is not there in the peripheral part of the nervous system. And although cranial neuropathy is an emerging phenotype, the most common cranial nerve so far being reported is a trigeminal nerve or a oculomotor nerve, both of which seem to be spared in our case. So currently there seems to be no uniform standard for the diagnosis of MOGAD with cranial nerve involvement, and this case exemplifies this unmet need.
So
Thank you, Dr. Rohit. Great case. Yeah, I think we can say that this is more of a brainstem involvement
Yes, ma'am.
and not a cranial nerve involvement itself.
Yes, ma'am, brainstem.
Can you say which are the points in your case of these which says it is intraaxial versus an extraaxial involvement?
Ma'am, the points, like supposedly, first of all, long tract signs like ataxia per se is a long tract signs. We have presence of an ataxic symptom. So it looks, and it looks more of a cerebellar ataxia kind of. So that one favor suggests an intraaxial lesion. The other part, the presence of a Horner syndrome like feature like meiosis with ptosis is possibly a partial Horner's. That also supports an intraaxial lesion. Although not present in our case, the presence of INO will also support due to the involvement of MLF can also.
Sorry to interrupt, Dr. Rohit. Can I request you to stop sharing your screen?
Yes. Yes, ma'am.
And I think long tract signs,
Yeah, sorry, continue.
ataxia and pyramidal dysfunction can be seen even with extraction compression, like you see with CP angle tumors.
Yes,
But
ma'am.
sensory is very unusual with an extraction.
Yes,
As
ma'am.
you mentioned, presence of Horner syndrome and Abbe nystagmus, pure
Yes,
Abbe nystagmus.
Yes, ma'am.
That is a typical interaction. So that is there, it must be interaction.
Yes, ma'am.
And unilateral hearing loss is considered generally an extraction situation, but
Yes,
you can
ma'am.
have it with cochlear involvement. And you
Yes,
know that there is an ICA stroke, which can additionally, because there is labrador involvement,
Yes,
you
ma'am.
have, so it mimics a pure extraction.
Yes, ma'am.
And headache being fed late in spite of significant
Yes.
dysfunction, that again favors the intraaxial over an extra.
Yes.
A great case. I think there is only one more doubt. Diffusion positivity was there. Does it add to your diagnosis in any way, some of the parts of the diffusion pulse?
Well, it shows that some of the lesions are actually active currently, some of these lesions, and particularly like the paramedian medullary region being still active. I think the vomiting episodes which were refractory to medications, I think it were localized to the area proxima more so. So I think that adds to our localizing value most.
Active demyelination can have a diffusion pulse stating.
Yes,
But otherwise, if it is ABC low and it is persistent, lymphoma is something which warrants.
yes, ma'am.
The typical MCP lesions in your case, as you told, is
Yes.
highly understandable. Thank you.
Dr. Rohit, I'd like to add that as Shruti ma'am had said, active demyelinating lesions, the leading edge might sometimes show diffusion restriction. So that is something that can explain. And according to the MOGAD position paper, around 2/3 of the patients of MOGAD usually present after a fever episode. So actually a history of fever prior to the onset of symptoms is something that gives you a clue that this is unlikely to be MS or NMOSD, more likely to be MOGAD, because Adam-like manifestation is much more prevalent and common in MOG-associated disorders than the other two primary demyelinating disorders.
Yes.
I just want to add one clinical point here, Dr. Rohit. Very interesting case, and you showed some features of upbeat nystagmus.
Yes.
So I just want to add there that actually, unlike downbeat nystagmus, which has clear localizing value,
Yes.
the upbeat nystagmus, like you also pointed out, can have variable localization.
Yes.
And in fact, it can emanate from cerebellum or even in the brainstem, apart from the medulla, the pontomedullary junction, and even with the midbrain. So in classical neurology, we say that the upbeat nystagmus has less localizing value as opposed to the downbeat nystagmus. So there you can use the crossroad signs that you have to try to localize further.
Yes.
So in the case, important point was that the patient started with symptoms of area postrema, and so we are suggesting more of the NMOSD. The patient is also having joint pain. The association of connective tissue disorder is found to be associated with NMOSD more than the MOGAD. So in this way, we are thinking more of the NMOSD. But all the vascularity profile and connective tissue are also negative. NMO antibody was also negative. More antibody was found to be positive. So it is whenever the positivity of MOGAD is there, we kept the patient in the MOGAD group. So it is one more of a new learning point for us. And the patient is well on methylprednisolone, and we also added mycophenolate in this patient in view of recurrence.
Just one more thing. Thank you, Kavi sir. Dr. Rohit, you'd mentioned about the titers. So the strong positive and the low positive titer is usually used for cell-based assays, which are done by the live cell-based assays, which are usually not available. So whenever you're using a fixed cell-based assay, which is available 99% of the times with us,
Yes.
be it at NIMHANS or other private laboratories, you have to have a concomitant finding that is a supportive sign. So just saying that it was strongly positive, so that is not required, does not hold as of today, although there are studies that say that the specificity and the sensitivity of a fixed cell-based assay is nearly the same as a live cell-based assay. So the fact that you showed that there were supporting features actually goes in favor of a diagnosis of MOGAD.
Yes.
Okay, I think that we are done with our two presentations today, and both were very well presented too. So congratulations to both the presenters. Before we wrap up and I hand over to Ajay for the vote of thanks, I just want to say that this is the last session of the YNF this year. So a very happy new year in the coming year to everyone. And also that there will be certain changes that will happen in the YNF. All of us are looking forward to some thrilling changes that are coming up, which will involve more participation and further engagement from the YNF members. And so watch this space for further updates. And with that, I would like to hand over to Ajay.
Yeah, thank you, Divyani. So first at the outset, thanks to IN and also the IN digital team, which has helped us to bring this program successfully in a very regular manner. It was a very educative session today with excellent case presentations on a spectrum of neuroimmunology. I think we're all wiser because of these two cases. I thank Dr. Shruti for agreeing to be our senior moderator, being with us and giving us a valuable time, sharing your expertise. Your observations were very insightful and useful for all of us. Thanks again, Madam, for your involvement. Thank you, Shreyashi. Very smooth and effective moderation. We highly appreciate your efforts towards YNF. Thanks once again. Dr. Siddharth, you gave us a very detailed and methodical presentation. It was very well presented. A lot of learning points. Sort of a triple whammy, the case was. So thanks for sharing it with us. And Dr. Ayush, thanks again for your timely comments, which has helped to understand the case better and put things in perspective. Dr. Rohit and Dr. Kavi also gave us a very good case presentation. It's very detailed and methodic. Thank you for joining us today and helping us to clarify more things about the MOG antibody-associated disease. Divyani has been instrumental in rolling out these programs on a regular basis, and we can't thank you enough for your efforts. She also has very interesting plans for the next year with the YNF team. So like she said, watch out for this space, and we will meet you again the next year with renewed zeal and enthusiasm, and wish you all a very happy new year. Let's meet in the next year. Thank you.
Thank you.
Thank you.
Bye. Thank you all.
And thank you, YNF team.
Yeah.
Thank you.